Welcome to CardioCast. I'm Dr. Jim Dwyer. Before the news, let me introduce you to a new occasional segment on CardioCast. As background, my brother Jerry Dwyer is also a cardiologist and an entrepreneur. We will talk about the latest practice-changing news and innovations and welcome guests. What will we call this program where cardiologist brothers talk shop? Card Talk, of course. Today's CardioCast is followed by our very first Card Talk. In the news, findings from the multinational Pure study turns our notion of a healthy body mass index on its head, and a separate study backs that up. But first, a new drug class slashed LDL cholesterol with biannual injections. The small interfering RNA drug Inclisiran safely halved LDL cholesterol levels in more than 800 patients in a phase 3 multi-center study. The approach could offer an alternative way to harness the potent cholesterol-lowering power of PCSK9 inhibition. The Orion 11 trial enrolled more than 1,600 patients with cardiovascular disease, familial hypercholesterolemia, type 2 diabetes, or a high Framingham risk score. About half were randomized to Inclisiran, which was administered as a semi-annual subcutaneous injection. Inclisiran targets the messenger RNA for the PCSK9 enzyme produced in hepatocytes. That cuts the cell's production of PCSK9 and pulls more LDL cholesterol from the blood. After 510 days, Inclisiran patients saw an average LDL reduction of 54%. The time average reduction over 15 months of treatment was 50%, according to Dr. Kauzik Ray of the Imperial College in London. Virtually every patient treated with Inclisiran saw a consistent drop in LDL. The rate of treatment-emergent adverse events and serious events was virtually the same in the Inclisiran and placebo patients, and Inclisiran showed no signs of causing liver effects, renal or muscle injury, or malignancy. Dr. Ray reported the study results at the annual Congress of the European Society of Cardiology. He says Inclisiran could give doctors better control over medication adherence, and it may offer patients a safe and convenient new choice for lowering LDL cholesterol. Middle-aged adults with a body mass index in the overweight range had a significantly better adjusted survival during a follow-up of nearly 10 years than did those with a normal BMI. That finding suggests the current widely accepted definition of normal body mass index may be wrong. Dr. Daryl P. Leong from McMaster University and the Population Health Research Institute in Hamilton, Ontario, presented an analysis from the Prospective Urban-Rural Epidemiology Study, or PURE, at the annual Congress of the European Society of Cardiology. The PURE investigators analyzed data from a worldwide study of more than 140,000 people aged 35 to 70 years from low, middle, and high-income countries. They found that people with an overweight BMI of 25 to 29 had significantly better survival after a median of 9.5 years of follow-up than those with a normal BMI of 20 to 24. A BMI of 27 was associated with optimal survival in both women and men. But BMI paled as a survival prognosticator when measured against two other weight assessments. The first was waist-to-hip ratio, which adds the dimension of the location of body fat in the abdomen rather than just the amount. The second assessment was even more prognostically powerful. It's a novel measure that calculates the ratio of hand grip strength to body weight. That ratio assesses the contribution of muscle mass to overall weight. The optimal waist-to-hip ratio for survival is 0.8 in women and 0.9 in men. The optimal strength-to-weight ratio is 0.4 in women and 0.5 in men. That means that a man whose hand grip strength, measured in kilograms, is half of his body weight has the best prospect for survival. Dr. Solim Yusuf, Executive Director of the Population Health Research Institute, says there's still a lot to learn about obesity. We'll be right back after this message. And finally, abdominal fat as a better measure of risk than BMI was supported in a separate study presented this week. In it, visceral adiposity, but not body mass index or total body fat, significantly correlated with elevated 24-hour ambulatory systolic blood pressure. It was also linked with greater systolic variability and masked hypertension. Those are the primary findings from a study by researchers at the University of Pennsylvania in Philadelphia. Dr. Jordana B. Cohen presented the findings at the Joint Scientific Sessions of the American Heart Association Council on Hypertension, AHA Council on Kidney and Cardiovascular Disease, and the American Society of Hypertension. The investigators studied 96 hypertensive adults on a stable dose of one antihypertensive drug for at least 2 months, then correlated the findings with ambulatory blood pressure monitoring. They found a significant linear correlation between visceral fat and mean 24-hour systolic blood pressure. And patients in the highest quartile of visceral fat had a 6.3-fold greater odds of masked hypertension, normal in the office but high at home, compared with those in the lowest quartile. Dr. Cohen says the study findings suggest that central obesity in particular should trigger 24-hour ambulatory blood pressure monitoring. You can find these stories and more by visiting www.mdedge.com/cardiology or by clicking the links in the podcast notes. This week's contributors include Alex Otto and Mitchell Zoller. And CardioCast Cardiology News and MD Edge Cardiology are edited by Catherine Hackett. Remember, you can find CardioCast via Amazon Alexa, Apple Podcasts, Pandora, or wherever you listen to podcasts. And if you like what you hear, please leave us a rating or review. For MD Edge, I'm Dr. Jim Dwyer. Well, hello, everybody. I'm Jim Dwyer. I wanted to welcome our listeners today to the new MD Edge Cardiology podcast with the cardiologist Dwyer brothers. I'm Jim, and with me today is my brother Jerry, and we have also a special guest. But just a comment about myself. I've been in cardiology in practice since 1983 and did 30 years of interventional cardiology. Last few years just doing general cardiology. My really only unique feature perhaps is that 20 years ago after medical school, I went to broadcast school when I was still in St. Louis. And 20 years now I've been producing 1-minute general health segments primarily for radio. And over the past year, I've worked for MD Edge, recording their weekly cardiology podcast called CardioCast. So recently, the cardiology editors and people had this crazy idea of trying a podcast with my brother Jerry. Go ahead, Jerry, take it away.
Well, thanks, Jim. I first want to say what an honor and privilege it is to join you on the MD Edge CardioCast podcast. This is certainly going to be an interesting run. I've looked forward to this day over the last few weeks as we sat down to talk about this podcast. I am a cardiologist, electrophysiologist for over 27 years at Missouri Baptist Medical Center here in St. Louis, Missouri. It's a BJC health system. I visit satellite offices across mid-Missouri. Of note, I'm also an MD MBA. I'm a doctor, developer, entrepreneur. I've also been doing that for greater than 25 years. I participated in multiple clinical trials and love innovations and inventions worldwide. So hopefully we'll give a wide cast of ideas and topics and bring them to this podcast as well.
Today we thought we were going to talk about atrial fibrillation primarily, right? And some of the new technology.
Oh, absolutely correct. So
you want to introduce us to our guest who's going to help us not make fools of ourselves?
Thanks, Jim. I think today's topic will be atrial fibrillation. It is, of course, one of the most common arrhythmias here in the country. Karma Conley is associated with a company that was originally started in Sweden, Koala Life, and now is coming here to the United States this month. So I've had the pleasure of interviewing her, working with her, and I would like to introduce her at this time. Karma?
Thank you, Jerry and Jim. I appreciate you guys having me on today. And just a little bit on my background. I've been in the medical device field for the past 14 years. I started a previous company in the U.S. for neurosurgery and just moved into cardiology with Koala Life. Koala Life is a Swedish company that started in 2017, and in 2019 in February, we just received FDA clearance to be able to come to the U.S. and bring our device, which looks for AFib, to the U.S. market.
Well, I think that's great. And, Jerry and I had been talking about what to talk about, and Jerry and his innovations. And I guess I got thinking about things after, an article. I can't remember if I did a CardioCast on it or not earlier this year, but there was an article from the ACC 2019 where they talked about atrial fib screening making a huge difference in cutting numbers of hospitalizations and ED visits. I think it was published in MD Edge Cardiology in May of 2019. It was called the mSToP study. And in that study, they screened people with a wearable ECG patch. And in that study, they found out by the screening, people ended up having significantly fewer emergency department visits or hospital admissions. And the people diagnosed with AFib through the screening had a statistically significant 80% relative cut in hospitalizations and a 65% cut in emergency department visits during the 12 months of follow-up. So I thought that was pretty great stuff. And I think that feeds into the advancing technology and capability of making a better diagnosis in people on an outpatient basis.
Yeah, on that note, Jim, 60% of patients don't even know if they're experiencing an episode of atrial fibrillation. Oftentimes, you do get symptoms such as dizziness and shortness of breath, chest pain, but it's the ones that you really don't feel, and you end up having a stroke, which are very worrisome. And I think that this type of technology, especially for home monitoring, is excellent.
Well, how do you see the advancing technology fitting into all this, and especially with new devices like Koala has and other devices that are out there? You think that's going to make life better for everybody, I hope?
Oh, absolutely. I think technology to detect early atrial fibrillation, technology to help with the treatment of congestive heart failure, technology not only for atrial fibrillation, but for other arrhythmias such as, of course, atrial flutter, supraventricular tachycardia, pauses, and VT are all coming for home monitoring as well.
What do you do when, just in general terms, some patient shows up into the office or even, in the primary care office complaining of palpitations? What do you normally think of doing first?
I think the first, second, and third choice is to do an electrocardiogram. And that could be either in the family practice or internal medicine doc's office, or referred to a cardiologist as well. It's always, I think, important to make the diagnosis of atrial fibrillation. And once atrial fibrillation is diagnosed or considered, of course, the big thing to treat is prevention of strokes.
And after, the EKG obviously doesn't have a great yield. A lot of times it's pretty normal in the office, or just some APCs or PVCs. And then what's your next thing that you jump to on patients?
I, of course, address the issue of anticoagulation. I also try to make sure if, in fact, I consider that it's a rapid atrial fibrillation, then
if atrial fib hasn't been identified yet, what's your next device?
Well, then I would definitely hook up some sort of monitoring, 24-hour Holter monitoring, to try and make the diagnosis.
You still do a lot of those, or you do longer monitoring?
Well, the thing is, it depends upon the insurance companies.
Yeah, but if the insurance company isn't in your way, what's your choice? Is it a 7-day, 3-day, 7-day, 1 month kind of thing?
I would definitely start with 1 month. I think the likelihood possibly of having another episode within the first 7 days could be low, and I think that putting on a 30-day would probably be the way to go, at least initially. Longer if possible.
Karma, how do you see koala kind of device? Maybe you can tell us. I've looked at your information and learned a little bit about it, but can you tell us what koala does and how it's kind of different? And between you and Jerry's got some experience with it. Between you two, can you tell us how that fits into the whole scheme of things?
Yes. So the koala is basically it's a patient-engaged device. So it looks at the chest for 30 seconds and then also your thumb ECG. And we look at 2 different locations to reduce the false positives. And from there, on the patient's phone, they will see their ECG. And then there's also a portal that the physician can also look at and see all of the recordings. So we always suggest morning, night, anytime you feel any palpitations. So this is great for those patients who you've tried a halter, you've tried the patch, and they still say that they feel things, but it didn't show up there. They can go home with this. It could just be stress. It might not be actually AFib. It might be something else, but this at least shows them, hey, my ECG was good. There's nothing wrong with me. Okay, great. So it's just a better quality of life by them looking at and actually having real-time data in front of them.
So
Jerry, how are you using it in your office?
It's also real time for the patient, but does it have real-time capability for the doctors too, Jerry, or what?
Yeah, there is a center that will be, first of all, it incorporates artificial intelligence, correct, Karma?
Yes.
So, and it's number 2.
Yeah, so every time we use it, it's real-time diagnostics, and every time we use it, all of our algorithms get smarter and smarter as it goes.
Correct.
That's kind of unlike me.
I wasn't going to say that, brother, but that's okay. Maybe there's machine learning for you after all.
I need a little artificial intelligence some days.
Right.
So go ahead.
I think these smart devices are moving from the fitness tracking arena to monitoring patients with chronic illnesses. And this is the real key here is that it's in real time. And the diagnosis can be made, and the patient and the referring physicians can be notified as well.
So how does that work in the real world? I mean, to me, when I first looked at the koala stuff and some of these other real-time monitoring things, are you going to have, I don't want somebody calling me every hour of the day or night. You foresee a central monitoring center for a lot of physicians to be able to use, or what?
We will have a monitoring center. We're signing them now, and we will have it so that there is a monitoring center. Well, they would get a report from the monitoring center, so that the physicians aren't getting called all the time.
So in the middle of the night, I'm not going to get a call from the monitoring company, but does it get reviewed at night by a physician?
Yes.
Or it does? Okay.
There's 24-hour, they're looking at all the ECGs for 24 hours a day, 7 days a week. So there is someone reviewing them at all times.
Yeah, I think that like with some of the other systems that you can set parameters of what to be notified with and what not to be notified with, but everything that's accounted will be transmitted probably in the morning. Is that correct, Karma?
Yeah, so typically, I mean, when the nurses come in, they can pull up and see what's come in from the night prior, and we have it color-coded, so it's green if everything's good, it's red if they need to check something, but the monitoring system that's active would have already looked at it beforehand.
So how about the patient in the middle of the night, doing a check and worrying about it? They get immediate feedback on their phone or what?
Yes.
Okay.
It will go to their phone, and then the monitoring center will contact the patient, or if an ambulance is needed, they'll have an ambulance come. That's what the monitoring center will be doing.
So if it's just somebody's feeling palpitations, but it's actually a normal sinus rhythm thing, do they just get like a text message back saying, chill out, don't worry about it, that it's okay, or what?
Well, on the device, on their phone, it will tell you if it's a normal and it's blue, it's pink if it's abnormal. And if it's pink and it's abnormal, we always tell them to do it again. And the monitoring center will be watching it at that time, and they will then text or send a note to the patient that everything is fine. It was because maybe they didn't have it completely on their chest with good skin contact, and they see a gap in the ECG or something like that. Because what they see on their phone right in front of them is actually the thumb ECG. And unless they go to the corner and they look at the PDF, then they would have the chest and the thumb. But, I mean, they're not going to really know what they're looking at anyways. So this is why we have a monitoring system there. All that we want to signify is, yes, it's great. Don't worry about it. You're stressing. You thought you felt something. Nothing was there. Or, yes, you felt something, and we did find that there was something there.
Now,
Jerry, is this device or other ones, are there any capability of ST segment changes compared to the patient's baseline? Is that capable with the technology that's there?
As far as I know, it is not FDA approved for that yet. Is that correct, Karma?
Correct. Right now, it's just approved. We're doing the P-wave for our diagnosis of AFib, but other than that, the other categories and everything else is not approved or cleared in the U.S.
And how about across the pond in Europe? And do you have other approved indications?
Yes,
for the device?
we have 9 different categories in the European model. I don't know all of them in depth, so I wouldn't want to lead you guys astray, but they do have additional indications, and we will be going in to the FDA for those additional indications.
I think what some of my patients really like about it is there's no sticky patches. And what I like about it, it's a two-channel system, correct? I think that's important to the ultimate interpretation of the rhythm. And you did
that is correct. Because a lot, what has been shown is systems with only one lead sometimes have false positives. So by taking it from 2 different leads, it helps reduce that false positive.
Correct. And are there any other FDA approvals on the device? besides the rhythm? Is there any oscillatory approval yet for heart
Yes,
sound?
so right now we do have approval to, there's a stethoscope integrated into the system that allows to look for heart murmurs, and that coincides with what the ECG is. And so when the patient is taking their chest recording, we ask for them to be seated and to be quiet so the stethoscope can listen to the heart at the same time.
Is it really listening for murmur? Presume it's also listening for irregularity of the rhythm too, which is, I guess, both important, Jerry, or what?
Yeah, I'm kind of fascinated with that technology as well. I haven't fully explored it, but I'm sure the FDA would not have approved it if they didn't feel there was significant data to warrant that from the European studies to here in the United States. So the possibilities of using this device, not only for detection of arrhythmias, but and it's not approved yet, but certain into the areas of congestive heart failure, and I could only speculate things like lung sounds could also be considered, and there could be other areas of impedance that could be also aid in the diagnosis of impending congestive heart failure. So there are also other things that I'm sure that people a whole lot smarter than myself can figure out and move forward. But this is a great start, and I'm anxious to utilize it here in my practice.
Karma, are there, you probably don't want to talk about competitors or things, but are there any other companies out there kind of doing this same sort of thing or similar to it? I haven't heard about any with the auscultatory capacity, but are there or any close competitors?
We have competitors looking for AFib. Majority of them are using one lead, and ours is only a physician-based product. So ours is RX only. A consumer cannot go out and buy this product, where other products are consumer products. And so they can buy it on Amazon, they can buy it at a Best Buy. So, and we are the only one that actually integrates the two leads and the stethoscope.
I've had a couple patients with the Apple Watches and whatever the version is for the rhythm strip. It's been helpful a couple of times, but again, I'm not overly familiar with how it fits into the overall scheme of things. How about you, Jerry? Have you had a number of patients with the Apple Watches or the
yeah, a few.
It's called Cardia device or something?
Yeah, I haven't used that one as much, but I'm always a little concerned. Just upon, I like the fact of this setup. I'm looking forward to using it. I think that the capabilities to get approval for other rhythms hopefully will be forthcoming. I think oftentimes I've had some disconnect between having a Holter on and having someone's own private watch on. And I know there is some good correlation, but and some of the studies, I think Stanford's put out a study recently on one of the Apple Watch and in hospital rhythm strips, but I haven't yet at this time promoting it in the practice. However, quite a few of them are in from my patients. So I think that will be forthcoming as well.
So Karma, going back to the notification of the patient themselves, since this is prescribed by a physician, does the patient signing up for this, do they give permission sort of in a sense that if the monitoring company sees something pretty bad or they're not getting the response or through to the patient, is there a system to contact the local ambulance paramedic system?
Yes, yes, there will be a system in place. We're working through the hierarchy now on when they call and those type of things, but there will be a system in place, because if they see something that is life-threatening, that's why we have the monitoring center, so that they can then contact the emergency, whatever needs to be done for that patient.
So if it looks like VTAC, they'll help get somebody there.
Yes.
In time. How about, I know Sweden, where it originated in Sweden, correct?
Correct. Yes.
Tell me, even though we don't have the FDA approval for stuff here, are you aware of how it integrates into the health system in Sweden? Some of the studies they've done in that and the successes they've had over there?
Yes. So they just did the Red Heart study, which was with 1,000 women. And they each had a koala for, I believe it was 30 to 60 days. And they showed that there was a better quality of life because females stress a lot, and they think there's always something wrong with the heart. And them seeing the immediate response has helped reduce that. They did catch AFib for some of the patients who actually had been to the cardiologist. But with their health care, sometimes it's 6 months to 8 months before they can see a cardiologist. So a lot of them, it's a consumer-based product in Sweden. So we do have clinicians there, but they can purchase it on their own.
Interesting.
And then, yes, and then in the Netherlands, we're looking at doing a virtual care type, where this will be part of a package that basically the patient goes home with it as a whole kit with blood pressure, looking at their weight, a whole little kit for virtual medicine. We're working on stuff on that end also.
Yeah, Jerry, you mentioned something about that to me in the not too distant past. Is there something in the works in the U.S. for some places to do that kind of project?
Yes, there are some major health systems that, of course, atrial fibrillation being the number one arrhythmia, almost 5 million individuals, especially over the age of 65. And by the time you're 80, 1 in 10 people actually will have atrial fibrillation. So it is very important for the diagnosis and treatment and management. So there are some major health systems, major insurers that are looking at this issue as well moving forward. And that coupled with the, just the overall having atrial fibrillation and developing congestive heart failure, that's also leading towards trying to develop all these home monitoring abilities for some of the highest at-risk patient population to manage healthcare costs.
How about in the world of electrophysiologists and like patients post-ablation procedures? Do you see this as being helpful in the patients having recurrences documented?
Oh, I think the potential would be great, especially in the first 30 or 60 days. As far as I know, with this type of system, there are no clinical trials, but I'm sure they'll also be on the horizon as well. I think recently, just the past 5 days in Paris, there was a gathering of 30,000 plus cardiologists, scientists, and innovators. And I think koala was recognized as some of the potentials, especially in the European communities, that can come together to reduce some of the significant complications of AFib. Was that correct, Karma?
Yeah, we were showcased in the digital health section of the meeting, and we did have a couple of presentations and posters presented during this meeting. And it's kind of the trend is to go towards more of the virtual care and digital health, where we can all be on a platform. Everyone can see it. The patient can be at home. and not in the hospital or in the office.
Okay. Well, how soon, Karma and Jerry, is this kind of technology or others close to it, or really how soon will it be spreading across the U.S. for us other kind of people to get our hands on it and help patients?
It's available now. We're launching in the U.S. this month. We'll have a press release going on in a couple of weeks, but we have product here that is ready to go for any of the physicians that are interested.
Okay. How do you have a number of different monitoring stations set up across the U.S., or is this going to be one primary one to start with?
We're just going to have a primary one to start with, and then as we grow, we will add them on as needed.
Okay.
Absolutely. I think, Jim, you sent me an article about the Australian study that found that personalized home-based educational symptoms for patients living with AFib can dramatically cut their hospital stay up to 26%. I think atrial fibrillation is so important across the globe, and this whole home-based education and learning programs for AFib I think are key, and I think I can see Koala being part of all this moving forward, and with the ability to be home monitoring would be great. And I think it's also very important in the cryptogenic stroke initiatives to try to ultimately make the diagnosis of the underlying etiology. So, I think this is, it's here. As Karma said, I think it's going to be across the country. I think hopefully that some of the other indications will be approved. And I think they're very important for atrial fibrillation for our patients and for healthcare costs and management.
Well, it's pretty darn exciting, and artificial intelligence has certainly found its way in the midst of medicine tremendously over these last few years. It's going to be very interesting to see where it all ends up. Well, thanks, Karma, for joining us today, and appreciate it. Jerry, any
thanks for having me. I really
of,
appreciate you guys having me on, and good luck on your new podcast.
Very good. Any final words of wisdom, Jerry?
No, I think that in almost every field of medicine, innovations, inventions, especially utilizing artificial intelligence, is not going to replace us, luckily, Jim. I think it's going to help augment us. I hope will make us better physicians. Machine learning, especially in the fields of radiology and pathology, are just really now being used and being reviewed and understanding the potential. I think things like cardiology, hopefully we'll have more podcasts on many different fields of cardiology where artificial intelligence is blending together with good old clinical medicine, cardiology, and also in the realm of surgery. So the ability to blend it together moving forward, to manage health care costs, to maximize patient outcomes and survival will be very exciting. It's not that artificial intelligence is certainly new. It's been around from the 50s and 60s, but right now I think probably in the next decade it's going to just take off. So I'm excited. I'm excited to be working with my brother, and I'm excited to be able to interview people like Karma from Koala Life and learn about their new technologies and the applications they will be used for taking care of my patients and your patients and many patients across the United States and the world. That'll be great. It's been fun.
Yep, and mention to listeners that maybe down the road, periodically we'll have our other brother join us in this. So we actually have a guy named Joe who's older than us, who's also a cardiologist, and we kept him off the first show, at least from my perspective. He's a heck of a lot smarter than me, so didn't want to get overly embarrassed the first time out there. But
I share that fun.
All right. Well,
All
from
right.
The Edge, I want to thank everybody for listening. Appreciate it. Bye-bye.
Thank you. Take care. Bye-bye.